endocrine system, and we're going to kind of focus on a couple of different processes in the body, but we're mainly going to be focusing on the thyroid, parathyroids, and adrenal glands, problems that kind of occur with those systems. Here's a copy of your learning outcomes. More learning outcomes. So this is kind of a quick slide of what we're going to be talking about. We're going to be kind of focusing on our hypothalamus, our pituitary gland, our thyroid, and our adrenal glands. That's kind of what we're going to be looking at, targeting those medications that are going to affect those systems. So in your body, whenever you have an event happen that causes your fight or flight response to kind of peak and you need to get away from something really, really fast, well, that all involves your nervous system. But let's say that like the first initial excitement of a tragedy or something, a big life event, let's take a hurricane, for instance. So when a hurricane first hits landfall, your body is really kind of functioning off of the CNS system, off of the sympathetic nervous system, right? But that event is going to last for time and over time. Well, your sympathetic nervous system can't continually respond. So what has to happen is that your body has to go through hormonal changes in order to protect you and to keep that fight or flight response, or to keep that body going in that high state of activation. So the nervous system is kind of like, I need something to work now. And then the endocrine system kind of follows up behind the nervous system and really helps to support and elongate the responses that we're having, or to change those responses over time. We see the same thing kind of play out in our body when we talk about our acid-base balance. Remember, whenever we need a really, really fast shift in our acid acid-base status in our bodies, the lungs are the first thing to respond and helps us to shift pHs really fast, versus our kidneys, which are much slower to the action. It takes a couple of days for them to actually change our pH. So the same thing happens here. Our nervous system acts really, really quick to make sure that we are up and going and moving, versus here, our endocrine system may take a couple of days to fully mount a hormonal response so that you can have life-sustaining measures, okay? This is a great diagram of all the intricacies that are going on in your head, from your hypothalamus down to your pituitary. And then it even shows you, like, from your anterior pituitary versus your posterior one, where all these hormones are coming out of, and then what's their target organs. I will tell you that as we go through and we study about our endocrine system, trying to kind of like think about what each one of these different types of hormones is responsible for can be a kind of a big deal. So there's a little box here, and then in addition to that, in the course, I gave you a one-page slide that kind of has the hormone on it, what it does, and where it targets at. So with the hypothalamus, one of its greatest jobs is that it's constantly measuring the feedback of the body to determine what's going on and what hormones need to be upregulated versus downregulated. This is called a negative feedback loop. It's either saying turn that on, turn that off, oh, not too much, and it back and forth, back and forth. The hypothalamus relays a lot of information down to our pituitary gland. And your pituitary gland literally sits at the end of your sella caternica, which if you took your two fingers and stuck them up your nose and pushed down slightly, you would be in the anatomical same place as where your pituitary gland lies. So the pituitary gland plays a lot of functions and has a lot to do with our hormones and the way that they affect the various body systems in your body. As you can see here, everything from your adrenal gland down to your kidneys is affected by this little pea-sized gland that just sits just on the inside of your sella caternica. The other thing that's up in there is called your pineal gland. It sits pretty close to your hypothalamus gland. The only reason I bring that up is because your pineal gland, as we age, tends to atrophy. The pineal gland is responsible for distributing melatonin. Melatonin is the hormone in your body that makes you sleepy, and it makes you sleep all the way through the night. So as our patients age, that pineal gland begins to atrophy, and as it atrophies, they lose the ability to sleep soundly through an entire sleep cycle. So we're going to move on now, and I want to talk to you a little bit more about negative feedback. So negative feedback. Guys, you know this concept already. The reason I know you know this concept is because you have an air conditioner in your home. Well, at least I hope you do. So with a central air heating and cooling system in your home, what happens is that the air conditioner will temporarily turn on, suck air through the system to test for what the temperature is. If it says, hey, the temperature is good, we need nothing, it does absolutely nothing. But if it detects that the temperature is not to what your desired level is going to be, it's going to turn the system on and cool it down until the air temperature reaches that level. Okay, that's the whole system of negative feedback. We have a couple of different places in our body that use negative feedback: temperature regulation, glucose regulation, hormone regulation. Guys, it's everywhere. Okay, and again, just remember, it's the Goldilocks principle. Your body wants to be not too hot, not too cold. It wants to be just right. And it does this with every one of your hormones in your entire body because it wants to have homeostasis. This is a really cool company called Bio Ninja. If you ever need some help with some anatomy and physiology, maybe you're just confused about something, they give some really great cartoonish, easy to understand answers about a lot of anatomy and physiology, and it helps me out a bunch. So let's kind of break this down, and I want to kind of spend some time talking about different parts of the pituitary gland. We know what the hypothalamus does. It relays information down to the pituitary gland, but the majority of the problems that we're going to be talking about today kind of lie at the pituitary level. Your anterior pituitary regulates the following hormones. You can kind of see some of these in here are really about growing. Your thyroid stimulating hormone comes from there. Your adrenocorticoid hormone comes from there. And then follicle stimulating, luteinizing, and prolactin. So that helps you to make an egg, lay an egg, and it allows you to feed the egg with prolactin. The intermediate, we really don't know what it does, but we do know that in rats that there is some hormone transmission that happens on there, but we don't really know what ours specifically does. So right now we'll just leave it to where it is. The posterior pituitary does secrete oxytocin and also helps to secrete vasopressin, and so we'll talk a little bit further about that when we get down into that section. So here's a trivia question for you. I'll keep you intrigued through the whole lecture. What movie made in 1991 based upon a popular 1970 TV show featured two actors, not one, but two actors with growth hormone abnormalities? Stay tuned, I'll tell you at the end. Don't look ahead. It's a lot more fun to trick you. Okay, so the first type of hormone deficiency that we're going to talk about is we're going to talk about growth hormone deficiency. So growth hormone deficiency is one of those ones where on the outside it looks pretty simple. You're like, Ms. Hardy, I could tell if someone's got a growth hormone deficiency. I mean, I see them. They're small, they're little. The growth hormone deficiencies come in a lot of different flavors in an endocrinology world. You can have proportional dwarfism, non-proportional dwarfism. You can have dwarfism that it looks like they are a dwarf on the outside, but on the inside they all have all normal sized organs. Or maybe they're a dwarf on the, they're non-proportional dwarf, and they've got like the top of them is a proportional, but then they're non-proportional. It gets into a whole bunch of crazy things. I just need you to know that as a nurse, part of our responsibility is to make sure that when our patients are coming in, that one, that we're encouraging them to come in yearly for their physical exam, and that two, if we begin to see someone who's falling off of the growth curve, that we're notifying the primary care physician for follow-up. So we have a lot of times, or not a lot of times, this is always diagnosed in childhood, and we try to intervene at an early age before the epiphyseal plates close. When you are a child, you have these little spaces in between your epiphyses of your bones, and as long as that plate is open, we can alter how tall or how short you're going to be, okay? Once that plate closes, then the medications that we give can no longer interact into that epiphyseal plate, and we can't make the patient grow, okay? This is the medication called somatriptone. It is a recombinant DNA growth hormone. It does help them to grow taller, bigger, faster. Problem is it has to be given subcutaneous, which, as you know, this is given to children, so not always gung-ho compliant children. We have to give it before the epiphyses fuse, and it can sometimes add as much as 6 inches of height to the child. It does have some side effects that the patients need to be made aware of, especially mom and dad. Remember when you were small and you were growing and you would get these horrible growing pains in your legs and you thought to yourself that you were just going to die? Well, these kids are going to get that same thing because this medication is going to stimulate linear growth. So bone pain is going to really be a thing. And they're going to feel really like as their body is trying to make more cells, it's just going to take a lot of energy. So they're not going to feel very good. This does come with a very expensive price tag, $30,000 to $50,000 for 1 year of treatment, and that approximately will get you about 6 inches. So let's talk about growth hormone excess. Typically with these patients, we can see it in one of two flavors, either before the epiphyseal plate closes or after. If it is happening and they've got too much growth hormone that's being produced in the body and the epiphyseal plates are open, man, that just goes in there and it'll expand those bones and those patients will be really, really tall. If the epiphyseal plates are closed, then what we see is not bone growth. Well, we will see bone growth, but we don't see it in the form of giantism. Instead, we'll see some other facial abnormalities, hands, feet, facial abnormalities that we'll talk about next. For our patients who have growth hormone excess, we have 3 different treatment options: radiation, surgery, and then medication, of course. So here's our most famous patient who most likely suffered from both giantism and acromegalia, maybe more acromegalia than giantism. He was pretty tall. That would be President Abe Lincoln. He was about 6'5", and for his time, that was a very tall individual. So with this patient, what we're going to see is that there can be like a protruding jaw, increased blood pressure, CHF, these very coarse facial features, enlargement of the soft tissues like the tongue and the skin and even some of the organs. It'll become kind of apparent here in just a second. I have a couple of photos of some modern day people who are suffering from both hyperpituitary and from acromegalia. Here's our medication, bromocriptine. Again, this medication has a couple of different uses. One of the uses of this medication is not only the treatment of acromegalia, but also prolactinomas, which is a tumor of the pituitary gland that affects the cells that secrete prolactin. So for instance, you might have a male patient who comes in who's like, I've developed breasts and I'm leaking breast milk. Or you'll have a female patient who presents to you who is also leaking breast milk whenever they're not pregnant. That would all be an indication of a prolactoma or a tumor on their pituitary gland. We'll also see bromocriptine used in Parkinson's disease and type 2 diabetes, but honestly, type 2 diabetes, I've never seen it used. That's a very old usage for the drug, but I just wanted to bring it up just in case. Anytime you have a patient who has heart disease, renal disease, or psychiatric disorders, you got to be careful about giving them any kind of medications. And the reason being is because is what we're fixing to give them going to make them worse than what they were before we treated them, okay? I'm going to say a life lesson here, and I don't want anyone to get offended or upset because I think you'll remember it for the rest of your life. You don't get to be crazy until you're healthy and crazy. This medication, bromocriptine, can cause a psychiatric disorder to get even worse, okay? So we need to know that this patient is healthy before we get started with the bromocriptine. And if we put them on there, then we're monitoring for that psychiatric condition to come back to the forefront, okay? You don't get to be crazy until you're healthy and crazy, okay? So we're always looking for reasons that are causing a psychosis in a patient before we just say, that patient's just crazy. No. You don't get to be crazy until you're healthy and crazy, okay? Bromocriptine tends to be one of those medications that can be tolerated pretty well. Sometimes not so much. It can cause, problems with the heart disease. It can also cause hypotension and a little nausea. It can be a little hard on the tummy. Ocitride is also another one of those medications that we give for patients who have acromegalia. You will also see this medication given quite frequently in emergency situations with patients who have GI bleeding. Okay. Also, patients who have diarrhea associated with metastatic tumors, this tends to help to relieve their diarrhea and makes them much more comfortable. So just let you know that yes, this has an indication in acromegalia, But if you have a patient who comes in with a GI bleed and the doctor is ordering this is the reason why. So here's Mr. Robert Walden. He was 8'11" whenever he passed away, one of the tallest men in the world, according to Guinness World Book of Records. He most likely suffered from just straight giantism. He doesn't have some of the facial features that would make me think about acromegalia, but when you look at the picture on the left-hand side of him standing next to his brothers and his nephew, you can see that his ears are abnormally large. We do find with patients who have giantism that sometimes even after their epiphyseal plate closes and they're no longer gaining height, that then their cartilage begins to grow. So maybe with his ears, maybe a little bit of signs and symptoms of acromegalia. It's really kind of hard to tell in this photo. Now this gentleman, on the other hand, this is known as, he was Andre the Giant, and Andre the Giant was touted as being one of the strongest men in the world. He also was a wrestler for WWE. Big, huge fella. Whenever he would go to talk, it was very hard to listen to him speak. He was very muffled sounding. In him, I can see more of the prominent brow, the more of the elongated jowl. Those are all signs and symptoms of acromegalia. So I would be highly suspicious to think that he had not only giantism, but also acromegalia. This is another WWE superstar. I know, classic TV. This is known as the Great Khali. He is 7'3", and like in the picture in the middle, he's sitting next to a guy who's like 6'3". So it's not like he's a small guy; he's a huge guy. But again, you can see the elongated jowl. They didn't want to let Mr. Khali have a speaking part on WWE. He always has an interpreter with him because supposedly he doesn't speak English. He's married to an English lady, guys. He grew up here. He totally speaks English. However, when he talks, again, you get that real muffled voice. And it's because patients with acromegalia, whose epiphyseal plates were closed but the growth hormone is still activated, tend to have atrophy of their vocal cords. So they lack the ability to alter their pitch and tone. Here's a sign, more of the classic signs of acromegalia that you would see. The picture in the bottom corner is the one that's most often in pictures in textbooks. You can really begin to see the patient's face change over the years. This wasn't like all of a sudden they just got this face. It's over time. And so being able to see the changing of a patient over time is incredibly important. I think about our patients who live in the nursing home, who people think, oh, well, that's just grandma. She got old and fat. Maybe not. Maybe it's this growth hormone is turned back on. And you can really kind of see in this photo here, I know it's a little bit blurry, but the bridge of the nose is really wide, and she used to have a cute little button nose. Then that jaw really started to grow out long, and then you can see the increase in the side of the feet. We want to catch these patients early in this, not later. And sometimes it can be really hard because this is a very slow disease, a very slow moving process. All right.